sorry for the technological glitch. Anyway, at the very outset, I would like to thank the organizers for inviting me to speak on this occasion. Next slide. So this would be the brief overview of the topic of discussion. We will be having a glimpse of time in range and its relevant clinical implication. What is the review of global recommendations on the same, and how do basal insulin therapy address the time in range, and finally make a comparative discussion between the second generation basal analogs in the light of time in range. Next slide. Now, before diving directly into the topic, let us have a few words regarding the background behind this discussion. So we all know that diabetes mellitus is an absolute pandemic in the non-communicable disease category, with nearly 400 million adults currently living with diabetes mellitus. And the alarming fact is that this number is expected to double by the year 2040 until and unless urgent reformative and corrective steps are not taken. So blood glucose management is of paramount importance to prevent the burden of micro and macrovascular complications. And in order to achieve the same, we try or strive to bring down the fasting blood glucose, postprandial blood glucose, and of course, the A1C. But is the scenario solved altogether? Let us see. Next slide. Next. So, in the last couple of years, there were a number of reports pouring in which showed that in spite of patients keeping the glycemic triad, that is fasting, postprandial, and A1C, well under control, there was an unexplained or paradoxical increase in the micro and macrovascular complications. And the answer, which was long elusive, finally was brought into light when we got to see the continuous glucose monitoring data of such patients, where they showed that these patients had undocumented pre-lunch drops in blood glucose as well as late post-lunch surges in blood glucose, and in some cases the drops in blood glucose again post-dinner, which were as usual not picked up by the standard markers used for the treatment of diabetes mellitus. Next slide. So why did A1C, a wonderful testing mechanism by itself, falter in this regard? It failed to pick up these evidences of surges and drops in the blood glucose profile of the patient. Next slide. The reason is that A1C by itself is not empowered to pick up these finer details of blood glucose profile. It does not capture hypoglycemia, and it's not empowered to pick up glycemic variability. Next slide. Next. So what is glycemic variability? It simply refers to the fluctuations in the blood glucose levels, both ups and downs, both peaks and drops in the blood glucose profile of the patient. And why is it clinically relevant? This accumulation of these daily basis ups and downs in the blood glucose profile leads to accumulation of high oxidative stress, and it has been found to cause poor quality of life and of course lead to the progression of both micro and macrovascular complications, independent of the burden of the duration or the degree of hyperglycemia. Next slide. So the beauty of this entity is best exemplified by this slide, where two patients are having the same A1C, but a simple glance at this slide would reveal that the patient one had much higher number of peaks and drops in the blood glucose on a daily basis. So this patient is having a high degree of intraday variability as well as interday variability, meaning simply this patient is at much higher risk of development or progression of micro and macrovascular complications compared to the second patient who had a much flatter blood glucose profile, in spite of the fact that both of them are maintaining the same A1C. Next slide. So what is time in range? Simply put, the period of time we want the patient to be within the acceptable blood glucose range, that is between 70 to 180 milligram per deciliter, that's time in range. So in a corollary, the period of time the patient remains in a blood glucose above 180 milligram per deciliter, it is time above range. And conversely, patients spending the time below 70 milligram per deciliter, it is time below range. Next slide. This is not to suggest that the advent of time in range or continuous glucose monitoring has made or rendered A1C totally null and void. This is in spite of the host of advantages time in range has over A1C, still they go hand in hand. How is it so? Let's see in the next slides. Next. So for every absolute 10% change in percentage TIR, there was around 0.8% reduction in A1C. So there is present a inverse linear relationship between A1C and time in range. Next. So this is a graphical representation of the same, the inverse linear relationship between A1C and time in range. The higher the time in range, as expected, lower the A1C. Next slide. So the situation can be compared with the analogy of a Maruti and a BMW car comparison. So Maruti cars are well known throughout the length and breadth of India for their wonderful reliability, safety, and convenience. But only when the driver shifts to a BMW, he actually experiences what he had been missing and what extra does this new car has to offer compared to the stable old Maruti. So it is only when we have the CGM data in our hand that we realize the fallacies of A1C and how do time in range of the continuous glucose monitoring data add to the current available knowledge regarding the glycemic profile of any individual patient. Next slide. So establishing glycemic variability is of paramount importance even if A1C is controlled. So it is important to minimize the glycemic variability even when the patient's glycemic triad is maintained. Next slide. So what happens if time in range is not maintained? So overall speaking, when time in range is deranged by 10%, retinopathy increases by a hopping figure of 64%, nephropathy significantly increases by 40%, and neuropathy by 25%. And current data also suggests there is increase in the risk of progression of cardiovascular disease and cerebrovascular disease by an increase in the surrogate marker like carotid intima-medial thickness. Next slide. Next. So it's no wonder that we have tried to move on from the era of glycemic triad to glycemic pentad, the newer incorporations being quality of life and glycemic variability, which encompasses both anytime hypoglycemia as well as nocturnal hypoglycemias. Next slide. And this is often broken down into glycemic hexad, where hypoglycemias are taken care of, again underlining the fact, the importance of minimizing the episodes of hypoglycemia. Next slide. Next slide. So the advanced treatments, technologies and treatments of diabetes in 2019 has laid down a detailed guidelines regarding the performance of continuous glucose monitoring and the analysis of the time in range data for different diabetic populations starting from type 1, type 2, pregnancy with the diabetes. I would not go into the details due to the paucity of time. Interested persons can go through this landmark guideline. Next slide. But it was not an overnight change. The writing was on the wall for nearly 10 years prior to the development of these guidelines. So it was a right time for change, for incorporating time in range in all the standard guidelines of the global bodies advocating the standards of care throughout the world. Next slide. So that is why the American Diabetes Association, in a special supplement published in 2019, 20, and 2021, have categorically mentioned the importance of maintaining time in range for prevention or the progression of macrovascular complications, and has commented that it can be used for assessment of glycemic control. Next slide. The American Academy of Clinical Endocrinologists has also toed the same line and have supported the idea propagated by American Diabetes Association regarding the routine incorporation of CGM data for preventing the progression of the complications in diabetes mellitus. Slide change. Slide change. But having said that, we must understand that despite its demonstrated value, time in range is seldom used in practice. The most important reason is that we physicians are often not aware of the nitty-gritties of interpretation of the CGM data, and often due to lack of logistics and lack of resources, financial constraints, lack of acceptability on the part of the patient, we are unable to advise routine continuous glucose monitoring to our patients. So the situation can be remedied to some extent if we advocate such standards of modalities of treatment, which automatically minimizes the glycemic variability and improves the time in range. So the big question is that, can basal insulin address glycemic variability and improve the time in range? Let us see what evidence has to offer. Next slide. So basal insulin, by its innate mechanism of action of targeting the fasting blood glucose directly and indirectly taking care of the postprandial blood glucose and having a thorough peakless action without having any significant peaks and drops throughout the 24-hour period, is likely to minimize the glycemic variability. And this is very much significant when we pit it against the older generation premixed insulins, where it holds a clear advantage over the previous generation insulins. Slide change. Slide change. Now we have moved on from the era of premixed insulins, and we have currently been able to lay our hands on the most recent basal insulins. That is, we are in the second generation basal insulins, and the two common basal insulins of the second generation which are available in the market are degludec and glargine U300. Now a question must be hovering in our mind that which one is better among the two, because we cannot make such a generalized statement that this molecule is absolutely better than the other. We can make an indirect comparison that in whose favor evidence is slightly tilted more. So euglycemic clamp study has showed lower glycemic variability with glargine U300 vis-a-vis degludec. So within their variability, with smoothened profile has been noticed with glargine U300 vis-a-vis degludec U100. Next slide. Next. Next. Next.
Dr. Chakraborty,
Yeah.
better to wind up rather quickly, because
there are only five minutes. I am already seeing in the screen there's 5 minutes remaining. Yeah. So I'll try to wind up in 2 to 3 minutes more. Let me have 2 to 3 minutes more. Yeah. So continuous glucose monitoring has also supported the same view involving a small set of patients. They have noticed a lesser glycemic variability with glargine U300 vis-a-vis degludec 100. Slide change. Slide change. Slide change. Yeah. So, and in yet another study, and again buttressing the findings from the earlier studies, they had noted that the percentage of time in nocturnal hypoglycemia, time below range, was significantly lower with glargine U300, that was significantly lower than that with degludec treatment. Now, why is this important? Because hypoglycemia can not only lead to hypoglycemic coma, the lack of treatment, but we must remember that diabetes mellitus is a cardiovascular risk equivalent, and any episode of hypoglycemia brings with itself intense sympathoadrenergic drive. So any patient landing up in uncorrected hypoglycemia can also happen to have any acute cardiovascular event. So time below range should be minimized as much as possible, and depending upon the small volume of evidence currently available, glargine U300 scores over degludec. So coming to the key points of the last 15 minutes of discussion, glycemic variability and time in range is associated with increased risks of severe hypoglycemia and diabetic complications, and of course, reduced quality of life. But still it's underutilized, and previous slide, please. And it's seldom utilized, and it's recommended to go for treatment solutions which take care of time in range, even though not regularly monitored. And in this regard, again, we have limited options in our hands, but second generation basal insulins have done or have been found to have a wonderful solution in this regard. And among second generation basal insulins, glargine U300 has been found to offer better advantage compared to its contemporary, the degludec. Thank you for patient hearing.